And welcome. Today, you're joining this webinar, which obviously we're focusing on the intersection of mass incarceration and public health. Before we get started, however, I just want to make sure that we introduce folk. My name is Andre Ward. I'm the Associate Vice President of the David Rothenberg Center for Public Policy at the Fortune Society. And on behalf of our CEO, Joanne Page, our Deputy CEO, Stanley Richards, and Senior Vice President, Rob DeLeon, we thank you for joining us for this important and very, very serious conversation and topic. Welcome to this town hall. When we're talking about the work of looking at mass incarceration in the intersection of that and public health, we know that there's a lot of research that's been conducted, and we know that many people are interested in the subject. When we think about the onset of the COVID-19, it really turned the spotlight on to the crossroads between mass incarceration and public health. Yet, its ramifications reach far beyond the pandemic. And so mass incarceration's negative impact on individuals' health is significant and far-reaching. And this also impacts people that are in prisons, their families, and communities in health crises along with their loved ones, especially those who are from Black and Brown communities. These urgent and alarming health crises or concerns are why we have convened this forum today, and we will explore and discuss how we can address our current condition and progress toward improvements and solutions. I want to thank, obviously, our communications team, Sarah Hershon and Kendall and Karen, who has worked tirelessly to make sure that this event is happening and taking place. So we're excited to have the discussion. We're thrilled to have our panelists, all of whom are experts in their respective fields. And just to give you a brief description of each of them before we get started into our series of questions, we have Romarilyn Ralston, who is the Executive Director of the College and Community Fellowship, which helps justice-involved women and their families access opportunity to higher education. She herself is directly impacted as a leader in the field, holds a master's degree, has won numerous awards for social justice and civil rights work. So welcome, Romarilyn Ralston, who joins us as well on this panel. We have Dr. Anaje Muid, who's a leader in social justice work and is a social worker and has been involved in the field of therapy for many, many years, specializing in trauma and substance use issues, racial justice, and innovative treatments while working to improve human rights in the social services field. Welcome, Dr. Anaje Muid. And we also have Dr. Jennifer Clark, who joins us. Dr. Jennifer Clark is a professor at the medical school at Brown University, and she was the medical director at a women's prison in Rhode Island since 1998, serving over 20 years. And her research has delved deeply into incarcerated populations and women's health, among other related areas. Welcome, Dr. Clark, who joins us too. And following Dr. Clark, we have Victoria Law, who's no stranger to the work in New York City in advocacy and journalism. Victoria Law is a directly impacted writer, teacher, and editor who focuses on the intersections of incarceration, gender, and resistance. And she has written books and articles covering the very subjects we cover today and guides impacted writers as they tell their own stories. Victoria Law, thank you so much for joining us. And following Victoria, we have Dr. Dana Rice, who joins us. Dr. Dana Rice is an assistant dean and assistant professor of public health leadership at Gillings School of Global Public Health at the University of North Carolina, along with her 17 years as a medical practitioner in an incarceration facility in Detroit. Much of her research and written work is applied to health for those who are incarcerated and their communities. Welcome, Dr. Rice. Thank you for joining us too. And then we have David Cloud, who's certainly no stranger to our work here. I've known David for several years, the work that he's done at Vera, but currently he works at the University University in San Francisco, and he is the research director at amend.org. His research and policy analyses cover issues at the intersection of public health, drug policy, and mass incarceration. And we're likely to have Dr. Wildman join us, but welcome, obviously, David. And Dr. Wildman, who may be joining us soon, is a professor at Duke University and an expert in public health, inequities, and mass incarceration. And he is especially known for research on the effects of incarceration on children's health, homelessness, and racial inequality. So thank you so much, everyone, for joining us today for this really, really important discussion. And we're going to jump right in it for the sake of time, and certainly because our audience has been patient enough to have you with us. And I'll start off obviously with you, Victoria, as it relates, and we center this conversation first on COVID-19, right? It's had tremendous impact, not only on our nation, but people who are incarcerated in jails and prisons throughout our country. And so one of the things that's been significant is, you centered your work, Victoria, around COVID-19 and how prisons and jails have responded to it. And could you speak to policies which have or have not been enacted and the resultant effects?
Sure. Thank you, Andre, for asking me this. So jails and prisons and immigration detention centers and other places in which people are locked in congregate settings have been hotbeds of COVID since the pandemic began, as everybody on this panel is well aware. Jails and prisons and other carceral facilities have varied wildly in their practices, some of which are not actually policies, but everybody knows that prisons and jails are fiefdoms in which the person at the top or the people at the top define the practices that then the people, staff members and others will carry out. So even if there is not a policy in place, there are practices that have been reported again and again from people in jails and prisons across the nation. So at the start of the pandemic, there was a lack of masks, a lack of PPE, there was a lack of testing. People were sometimes punished, sometimes brutally, for asking to be tested. One example in New York City was at Rikers Island, which was an early hotbed of the pandemic, where 7 people asked to be taken to the medical clinic. And here we can see how the carceral setting interferes with healthcare in that they have to be escorted to the clinic by a CO or a correctional officer. Instead of taking them to the clinic, which would behoove everybody incarcerated and staff to make sure that if they have a highly contagious disease, they be tested and identified and isolated, they pepper sprayed them and brutalized them instead. And over, we've heard during the early days of the pandemic that people were not being tested, they were refused testing. And then as the pandemic went on, we also heard that people were not reporting symptoms because they knew they would be thrown in solitary confinement. For viewers who may not know what that is, imagine being locked in your smallest bathroom. For those of you who live not in New York City, perhaps your bathrooms are larger, and not having anything. You don't get your books, you don't have your phone, you don't have anything, and you are just staring at the walls with little to no medical or mental health care. So what we've seen again and again is a failure on the part of jail and prison officials to actually enact policies that would help stem the pandemic. And instead, what we're seeing are policies that continue to punish people inside with very little information given as to why any of these policies are being enacted, even when they might have some root in public health practices.
And following that, right, I want to turn to you, Dr. Rice, right, because you've also looked at this. And could you share with us, some of your research regarding the pandemic and incarceration? Also, at the University of North Carolina, I believe you teach a course titled Mass Incarceration and Public Health. Therefore, you might have some things to say about the broad implication of resulting community health, especially for deeply affected communities. So can you speak to that, Dr. Rice?
Sure. I think what Victoria shared is broadly the experience that we've seen across the country with very limited coordination and collaboration between public health officials and local sheriffs or authorities who are supervising or responsible for supervising folks who are incarcerated. And so because of that, and because we sort of operate in these silos, we definitely have seen the broad spread of COVID in cases where we could have been more proactive at preventing COVID, both inside and as people were returning to communities or being released. Because one of the collective responses that public health practitioners were encouraging was active decarceration, which we saw the uptick in very early on and then the slow sort of progression back to current practices around bringing people back in. And we knew that creating opportunities for folks to not be in close proximity to one another is one of the key protective measures for preventing COVID, as well as providing PPE and opportunities for cleaning. And so I think the response was slow and limited at best and unsustained broadly, as we've seen an uptick back in sort of our old ways of practicing in the criminal legal system in this country. And so I think what we are seeing is that we haven't necessarily learned the lessons, because we also know that there wasn't any sort of large increase or uptick in crime as was folks were concerned about. If we would release people back into community, we would see some deleterious effects in community. And that wasn't necessarily the case. I mean, there's been evidence out of Rhode Island and other places that show that we actually didn't see that sort of correlation. And so I think that what we did see is that decarceration is possible as a strategy just in general for creating or sort of dismantling the system that has been so disruptive. But it's also been a life-saving measure for us, especially in times of a pandemic. As it relates to the course that I teach, I spent 17 years working, not as a medical practitioner, but as a public health practitioner in the jails in Detroit. And in my own public health training, both through both my graduate programs, I had very limited, if any, exposure to understanding the criminal legal system, yet I was simultaneously working behind bars at the same time. And so I found that if my interest was especially focused on addressing inequities and health disparities, and very quickly realized sort of that the importance of understanding the intersection between public health and mass incarceration if we were going to do anything about addressing health equity, right? Because of the large disparities that we see between Black and Brown people being locked up, sort of the conditions of which people are in when they come into facilities, their experiences in the facilities, and sort of the disconnect that happens when they're released. I felt the need that we had to do more. And so I created this class, which is, I think, one of very limited classes at schools of public health, to both train future practitioners of public health, even if they don't have an interest in doing this work specifically, because of the sheer number of people who are touched by this system. Not only the people who have been in the system, but it extends to their families, right? So when we think about the work of public health, we're talking about communities. We're talking about the collective community, collective society. And this system has had such a damaging effect on communities at large that I think it's our obligation to train future practitioners to understand both the challenges that are experienced as people interact with the system, and then their experiences in the system, and then what we need to do to sort of reimagine a new system of accountability and wellness and health. And so that's why the class was created. And it is to really just expand the reach of folks who are doing this work, and to hopefully use our tools of public health to reimagine some alternatives.
And thank you for that too, Dr. Rice. And as you referred to yourself as a pracademic. And so we appreciate that and value that. For those of us who are in academia and value that space, we definitely need that marriage between the two, right? So that we can train the next generation of pracademics or practitioners in particular. So I want to change like a little bit toward like health in and of itself while incarcerated. And, there are many health risk factors, both physical and mental, right? For those who are experiencing incarceration. So I want to turn to Dr. Clark, right? Your work in the facilities as a medical leader and professional, as a medical doctor, right, who spent like decades serving incarcerated people, can you shed some light on the negative factors affecting health in prisons and jails? Like, what might you suggest to improve or solve those problems?
That would probably take about 5 hours, but just to start off, one major problem that I saw when I first started was people coming in on methadone treatment for opioid use disorder, FDA approved. And it was the policy in the facility in Rhode Island to take everybody off of treatment, which made no sense to me. Eventually, we were able to turn that around when I became medical program director. It is so basic. It's such a basic treatment. And the fact that facilities across the country take people off of treatment and don't provide new treatment it adds to the problem, the public health issue of substance use disorder. So we really, taking somebody off of a treatment, having them feel sick, makes people more resistant to continuing treatment when they go back in the community. So we really do people a great disservice by taking them off treatment and by not providing treatment. So not starting treatment. That is also a huge area. Early on, I saw disruptions in family planning. They wouldn't restart. We didn't have any birth control on our formulary. So we take people off of their birth control while they're in jail. People would get out 3-6 weeks later and have unplanned pregnancies. So there are so many areas where it's sort of this double-edged sword. A prison or a jail is a perfect environment for public health interventions, but it's also a perfect environment to create public health problems when people are released. So just so I don't go on too long, does that answer your question?
No, I think that's fine, Dr. Clark. And just want to circle to David, right, whose research in this area is significant, right, and his commitment to it is well known. And, from a researcher's perspective, David, could you speak to the health conditions of those experiencing incarceration? What does that mean? And could you also talk about solitary confinement as a health issue? Right now, we know that on the state level in New York, the halt solitary confinement bill was passed, that there's still some remnants and elements of that on a city level being practiced, right, in Rikers Island. And that is looking to be changed in some way. But talk about that, Chris, if you can, right? Speak to the health conditions of those experiencing incarceration and solitary confinement as a health issue.
Sure. I think just basically speaking, from a health inequities, health disparities perspective, we know that across the board, whether you're talking about chronic disease, addiction, substance use disorders, serious mental health issues, infectious disease across the board, all those are alarmingly disproportionate among people who are in jails, among people who are in prisons. And, one of the things I'll say though is that as public health professionals, we do a terrible job of actually routinely tracking the health of people behind bars. The systems we have set up to really define the distribution of disease and morbidity and mortality in our society really eliminates them from the equation to a large degree. So we have to rely on people like this in this panel in this room to really do the behind the scenes work to let people know how grave the issue is. I think everyone probably here knows that the conditions within prisons and jails are deleterious to people's health. Everywhere from overcrowding to being in a room full of other individuals stacked on top of each other. So if we're talking about something like COVID, that's pretty obvious. But then if you're getting to just something like solitary confinement, more urgent, pressing, draconian human rights issues that are existing every day. There are about 60,000 people on any given day in state prisons alone that are in the size, as Victoria said, in the size of a bathroom. No access. Many of them are, have serious mental health issues. Some of the most marginalized, traumatized people in our society that I would argue there's a complicity in public health that we have failed them, and that we've abdicated our responsibilities to correctional officers and people who are untrained and different, or taught to be deliberately punitive to people who are frankly just need help. And I think we've missed them, and they're off our radar. And so I think there's back to Dr. Clark's point, this is something you go on for about 5 hours, but it's a humanitarian crisis. And I think, to just dovetail on what Dr. Rice was saying, we need a workforce of clinicians and public health people to actually be aware of this, but go inside, like a core of people to go inside and really start to unpack this. And there are a bunch of different things that people in public health do, whether it's direct service, whether it's something like mental health, but also just from a policy and a fundamental perspective of building an architecture around prison conditions, so that we know what's going on and we know where to focus our kind of priorities and energy. I guess the last thing I'll say on solitary confinement is that one encouraging thing with all this is that there is, at least on a legislative front, a big push to address this. And HALT's kind of like, HALT New York, that bill, the organizers there, I mean, that's just the most beautiful example I know nationally of coalitions of survivors of solitary who are really driving the conversation and pushing for comprehensive legislative efforts to address it. But it's coming from all angles, and it's coming from litigation-based kind of genesis of some of this, but also even in some places, some corrections people that are waking up. That's some of the work we do at Amend, is to show people who are working in these environments, like, look, there's another way to treat people. There's a shared humanity. Like, you don't have to go home with an elevated heart rate. And correctional officer health is actually, I think, an inevitable kind of pressure point that we need to focus on to get more buy-in for the people who have the most daily interactions with incarcerated people, to convince them that they better play a role in this. And they have to, because even with the best reform, the best laws, when it comes time to implement this stuff, they're going to be in the mix. So I'll stop there so I don't go too long, but
Sure.
that answer your question.
No, and thank you, David, for that answer too. And speaking of implementation and legislation, today marks the first day that the less is more parole revocation legislation is being rolled out. And so we're going to be monitoring that and see what is the impact of that legislation going forward. And so, speaking to your point, David, in mental health, in New York City, we know that particularly in Rikers Island jails, at least over 40% of folk who are on Rikers have some mental health diagnoses. And so I want to transition now to Dr. Mueed. Mental and physical health are both at the heart of our discussion today, Dr. Mueed. And, we also cannot speak to these issues without acknowledging and exploring the role like race plays in all of this. Could you speak about trauma and racial disparities for people who are in prisons and jails, and the mental health issues involved?
Thank you so very much. I'd like to reference Dr. Rice and Dr. Cloud's two things I pulled out in terms of this particular aspect of it. Is one, Dr. Rice said we need a new system. Dr. Cloud said that we need the human rights violations. So my comments are based upon, let's say, 3 books, which I put in the chat. One is called The Antisocial Contract by Yusuf Clyde. He says that in the very beginning of this country, there was an antisocial contract. Dr. McIntyre says from the very beginning, as we moved from chattel slavery into convict leasing system, there was a concentrated effort to make sure that this population that was brought here to serve a particular elite class would still remain in a subservient position. And then we move into the work Slave by Another Name by Blackman. So this is the underpinning. So if we ignore these underpinnings, every discipline says, what's the root of the problem, right? Calculus says, take the derivative. Medicine says ideology. Every discipline says, what is the root of the problem? Because if we're not attaching, understanding the root of the problem, only thing we're doing is treating symptoms. And we know that symptoms goes around and around and around. So when we talk about mental health, we're talking about, particularly of that segment that I concentrate on, people of color, African Americans in particular, we're talking about people who have undergone generations of oppression. So what happens? So if we look at the studies of genocide against the Jews, there's something called survivor camp syndrome. That is, generations of Jews who were not living in Europe are still suffering consequences of genocide. That birthed the field, what is called epigenetic transgenerational trauma. So now that same basic studies have been applied to people of African descent. And now we're saying there is a harm. So as the co-chair of INCOBRA's the National Coalition of Blacks for Reparations in America, as a co-chair of their health commission, we're saying there's these 5 injury areas, particularly people of African descent: peoplehood, mass incarceration, health, education, and finance. So with respect to mental health, we're saying that there is an overlay of this intergenerational trauma that's already present. So then when you take that and you compound it by incarcerating the people disproportionately, it exacerbates the problem in terms of not being functioning in the family, in terms of not functioning in the community. So we're saying that reparations really is the current issue. We're talking about a mega problem that can only be solved through a mega solution. So public health is that solution. So how can we now grow public health to take into consideration historical trauma, right? So we first have to declare racism a public health crisis. Without doing that, you're not going to get any traction, because anything you bring into existence is going to be half-baked and only partial. So we start with declaring public health a crisis, a public health crisis. This has been done like about 234 counties around the country. So it's starting to happen, right? We're starting to look at a new paradigm in terms of what is the problem, which is the continuation of colonialism to neocolonialism. And we started, Dr. Martin Luther King said in 1967 that Black communities are domestic colonies. Not Malcolm X, Dr. Martin Luther King, but how many people have heard that speech? So we're now in a new era of information, of understanding what is the problem and therefore what is the solution.
Thank you for that, Dr. Muid. And we want to turn to Mr. Walston, who is the Executive Director of College and Community Fellowship, again, which focuses on opportunities for higher learning for women. And could you shed some light on like the positive mental effects of education for individuals during incarceration? And also as a directly incarcerated, directly impacted person, would you like to speak about this from that perspective?
Well, thank you, Andre, for the question. As a directly impacted person, someone who spent 2.5 decades inside of a prison and used education as my transformative practice, it helped me to understand what systems are at play in the incarceration of Black and Brown people, and in looking at how mass incarceration impacts our communities. But for the conversation today, when we're talking about public health and healthy communities, we have to step back and look at where our incarcerated people are coming from in the first place. What do these communities look like? Most of our communities, as we've noted today, are Black and Brown communities. They're underserved. The public education system is underfunded. It's over-policed. There's a lack of parks, recreation, public transportation. There's all of these things happening within our communities. And like Dr. Onaji says, we're talking about historical trauma, intergenerational trauma. So when you are raised in communities that are underserved and over-policed and lack basic human resources, not only is it a public health crisis and a human rights violation, it sets people up to be relegated into these cages, into the carceral system. And when we get inside of these prisons, it's just an extension of the communities in which we've come from. And I love this quote by Dr. Angela Davis. She says, prisons do not disappear social problems. They disappear human beings Homelessness, unemployment, drug addiction, mental illness, and illiteracy are only a few of the problems that disappear from public view when the human beings contending with them are relegated to cages. And that's what we're talking about today. You know, we're talking about the prison industrial complex, the carceral system being an extension oftentimes of the communities of which people come from. And if we're not solving these public health issues within the community, they're not going to get solved within prisons. There is an aspect of education in prison that one can take advantage of, but it's not available to all. You know, resources in prison are limited, and there's a hierarchy of who gets access to certain programs while in prison. So mental health issues, socialization issues, substance abuse issues, all of these things are not being addressed to all people inside. You know, for some of us, we're able to choose education, and then that helps us to form a different relationship with others and ourselves. And so when we return to our communities, we're able to take a different look at it. And so we can now see where we've come from and also see how we got there at the same time. But when you're in it, when you're in your community and all of these things are happening to you and you're bombarded with the trauma of living in over-policed communities, poverty, under-resourced schools, unemployment, underemployment, you can't think about those issues because you're trying to survive the day to day. And so trauma just goes unresolved. And so I think to your question, what I'm trying to get at is that when we become incarcerated because of tough on crime policies, policies that stem from the war on drugs, institutions and prisons are not prepared to address these issues. The little bit of education that is afforded to someone inside is basically on a volunteer basis. It's not part of the draconian system that we have called corrections. Corrections is not trying to correct, they're trying to punish. So whatever rehabilitation one seeks or one develops when they're incarcerated, they develop because they see themselves differently. They want more out of life. They don't want to return to the prison system, and they're trying to break free of those chains. And so I think it's really important that we remember that incarcerated people are at a disadvantage when we enter into the prison system. Most folks think that the prison system is about rehabilitation and correction, and it's not. It is about punishment. It is about labor, and it is about removing people from communities because of laws that are set up to disenfranchise. And so we need to understand that.
Thank you for that too. And I want to circle back to a point that, Dr. Muid mentioned about looking at the whole picture, right? And understanding systems itself, and direct this question to Dr. Rice, right? You said, Dr. Rice, and I quote, if we're only talking about the disparities we see behind bars, we're missing the whole picture of understanding the system. And what we're seeing behind bars is just a perpetuation of those disparities we see in communities, end quote. Can you speak to that quote that I just mentioned from you?
Yeah, I mean, I think that, Ms. Ralston just articulated, I think, an example of what that quote means, right? Because in public health, we're trained to think about understanding, to Dr. Muid's point, root causes, where there's been sort of an emphasis on understanding social determinants of health, and sort of along with a recognition of sort of the historical perspective of how those disparities came to be, right? And so we have to acknowledge the role that I think white supremacy has played in creating this culture and this environment that has resulted in systems of oppression that have been built to that have been built and sustained over hundreds of years to keep people from being able to be their best selves, right? And flourish in environments that are created for health and well-being. And so I think what we need to do is shift our focus on primarily thinking about primary prevention, right? We need to talk about creating an environment that keeps people from entering into the system in the first place, because we acknowledge the harms that are caused both on the in those communities that are over policed and underprotected, in those communities that have been historically disinvested in, and think about what it means to create a system of health and well-being where people don't feel that they have no options other than to become or to make choices that are very limited in scope. And so I think we need to think about the work that we're doing from that historical perspective. We need to refocus our efforts on addressing the social determinants of health to create communities of health and well-being, to keep people out of the system, while simultaneously working to improve conditions of confinement for the 2+ million people who are currently incarcerated. And then I think there's a ton of work to do there to address the challenges, because as the examples that have been presented today really articulate that the system is not designed for correction or wellness. It is designed specifically for punishment, and we have to be able to reimagine some alternative solutions to holding people accountable and also setting them up for success for the future. So we have to think about the conditions of confinement and improving those. And then ultimately we have to think about what that transition looks like to support people from re-entering that system when they leave. Because if we don't do all of those things, like, we have to wear many hats in this fight if we're going to reimagine what the system looks like. And we can't do that if we're only sort of focused on one area without the acknowledgement of sort of the history that the creation of these systems was structured. So I think, there's also been lots of conversation relative recently, more than I've heard in quite a long time, around, especially around the racial reckoning, right? Where the conversation is more on acknowledging the historical harms, the historical traumas that have been created by these systems, to focus our work on addressing health disparities and addressing the concerns that we're seeing among Black and Brown populations, among poor populations, right? Like, we're acknowledging that these disparities exist and that we have been inadequate in our responses to address them because they have been sustained over such a long period of time. And therefore, I think we have an obligation to, if we're going to improve health disparities, if we're going to eliminate health disparities and achieve health equity in any way, we have to focus our efforts on understanding and reimagining alternatives to our current system. And that means dramatic thinking about, and it's possible, right? We're seeing cases across this country of folks thinking differently about how we address and deal with violence, about how we address and deal with each other's humanity, how we think about the long sentences that we offer, right? So there's a lot of conversation that's happening now that I think is focusing on addressing disparities. I think from public health, we need to make that connection between our inability to be able to address health equity or achieve health equity if we don't focus on addressing our efforts within this system.
Got it. And I want to turn to Dr. Clark, and following Dr. Clark, we get to Victoria. But Dr. Clark, based on your work with incarcerated populations, what are some of the irreversible detrimental health effects of incarceration, and what could be done to position people like in a healthier kind of way as they return to their communities and families?
I think lack of treatment, especially hepatitis C. Most facilities will not treat people for hepatitis C. I think we could build healthier communities by addressing the problems when people come inside. Worked with people at NIH, and the mindset seems to be We know interventions work better in prisons than in jail populations. So let's just focus on the prisons. I think that is completely backwards. Let's focus on the jails and have people never go to prison. Let's address health issues. People say things like somebody's only in for 48 hours. Why should we spend money on them? Well, let's invest in the health of an individual who's only there for a brief period of time, and hopefully set them up for success so that they don't come back in. I think we see a lot of traumatic brain injury. So from bites either inside the prison or in the community, which lead to impulse control issues. If we're not addressing that, if we're just putting somebody in solitary confinement, you're just making the problem worse. Mental health issues. Rhode Island is, it's not funny, I can't think of the correct word, but the women's prison and jail, Rhode Island's so small, we don't have any county jails, it's all just one system, one campus. The women's facility was a mental health facility, which they just emptied out and relabeled a prison. So we've got it all backwards. So unless we're addressing these health issues, and again, I'm a physician, so I think about the biologic more than the whole society, but racism in society is causing these problems, so that we're dealing with, as medical providers, we're dealing with the hypertension, the diabetes, the traumatic brain injury. If those aren't addressed, the problems just snowball out of control. So you have somebody who comes into jail, they're not given what they need for their hypertension, their mental health problems. It's the first offense, they get out, they come back in, they get out. If we're never addressing the problem, we have a system that's perfectly set up for long-term incarcerations. And we just need to stop it. We've seen with COVID that it can be stopped. We didn't see an increase in crime in Rhode Island. It is probably laziness on the side of the judicial system that we think, well, we'll just send somebody to jail for a $12 bail that somebody doesn't have access to. So we've got to address these problems early on to prevent these long-term problems. Oh, I think you're on mute.
Thank you, Dr. Clark. And I want to turn to Victoria. How can we improve health in the transition from incarceration to release? And also circling back to the pandemic, what can we learn from this experience to improve policies and programming going forward?
Well, I think first of all, what we can do is not rely so much on jails and incarceration. So if we keep people out of the system in the first place, then we don't have to worry about people being in these congregate settings where COVID, even a common cold can spread like wildfire, but something like COVID will spread and then people come back to the community. Dr. Clark mentioned that there's this idea that if people are only in jail for 48 hours, why should jails spend money to treat them? I want to point out that if you disappear for 48 hours and you've got children, small children who are at school, at the babysitters, not able to be picked up, those children are more likely to end up in foster care if you don't have family to take them. If you don't show up to your job with no notice for 48 hours, many jobs are not going to like that. And you may not have a job when you get out, which means you may lose your housing. So there are all these collateral consequences, first off, for keeping people in for 48 hours. And then according to the Wall Street Journal, as of last year, it costs $1,226 per day to lock somebody up at Rikers. So we're already spending a ton of money to lock up one person for one day. So people, viewers on this who are better at math than I am, $1,226 times 2 for that 48 hours for one day. We're already spending that money. So rather than saying, why should we treat people who are inside, we should say, well, we're already spending this enormous amount of money. How can we decrease the number of people going through that revolving door? And we saw that at the start of the pandemic when police were making fewer arrests, and we didn't see crime rates go up. In Atlanta, the number of people being sent to jail decreased dramatically and did not increase again, at least for their giant Atlanta City Detention Center, until the start of the Defund the Police Black Lives Matter protests, when protesters were being sent to the jail at large numbers. But in terms of people's health upon release, or trying to link that, as many panelists have said, we don't have connections between public health and what they call correctional health, or healthcare behind bars, or what passes for healthcare behind bars. For instance, even though there's a state vaccine registry, people aren't checking that. Health officials in jails aren't checking that when people come into the jails to say, hey, we noticed you haven't been vaccinated for COVID. Would you like a vaccine? Here are the facts about the vaccine. Or, hey, we noticed you got vaccinated 6 months ago with your first shot. Do you want to get your second shot while you're here? Because you're going to be stuck in that dormitory with 100 other coughing strangers for the next 48 hours. Oh, we noticed you got your second shot 6 months ago. Would you like a booster? Hey, there are these other issues that come up in the public health registry for you. How can we address them while we're here? But they don't do that. And then that's a very simple thing that just requires looking in the state database. So we see this breakdown of this idea that once you go inside, you're somehow removed. And there's no idea that there needs to be follow-up, that people come back out into the community, that there are staff that go in and out of the community every day. There have been studies that show that communities with prisons or jails have higher rates of infection, COVID infection, because staff are going in and out of these hotbeds and then bringing them back to their families and their communities and their own congregate settings as well. So I think that first we need to start with sending fewer people to these places. And then we can look at how do we then free up those resources of $1,226 per day per person to say, like, how do we treat the people who are in there, instead of saying, how do we treat the bazillions of people who are in there and take more money away from all of the social structures that have been constantly defunded over the decades, that have made many of our communities much less safe, much less robust, and much less healthy.
And now I want to turn to Dr. Cloud. Obviously, David, the work that you're doing, right? There's also a specific focus on current drug policies, right? In the intersection of that and with public health. Can you speak about public health and current drug policies for people involved in the carceral system? And how can that affect families and communities? And while we weren't joined by Dr. Wildman, he had an emergency. His area of expertise is around looking at incarceration and its impact on families and children and communities. But can you speak to that, Dr. Cloud, around public health and the current drug policies for people involved in the carceral system, how that can affect families and communities?
Yes, I think just to pick up on a lot of the threads that have been in this conversation so far, the war on drugs, its foundations, its roots are just fundamentally connected to racism. That's what they were enacted on. This hyperbole of fear, the tough on crime movement, that kind of punitive sentiment is baked into the way we think about drugs, the way we think about addiction, and our response to it. It's just, I think we have to chip away at that. It's kind of an all hands on deck approach that needs to be taken. So, first and foremost, jails are just the continuing cycle of people that come through that are in a current state of dependency, whether we're talking about heroin or opiates, other types of opioids, methamphetamine, cocaine, no matter what you're talking about, jails are going to be a place that disrupt people's lives. And people who are using drugs, especially chaotically, we know that those places are going to interrupt as the collateral consequences that were already mentioned. But just from a physiological perspective, say you're addicted to heroin and you go into jail, you may not get treatment. You may be subjected to an awful withdrawal process where you're laying on on the floor next to 15 other people going through just severe withdrawals, getting very bare minimal medical treatment at best. And then your tolerance goes down. You may stabilize a little bit, and without any support, no education on overdose prevention on your way out, you're headed back into the community, back to what you know, and you're going through pain, you're going through trauma, and you want to use again. If your tolerance is down, you don't have the tools. I mean, it's a big driver of the overdose epidemic. I mean, COVID's kind of taken over our worlds, but we can't forget that, over COVID, overdose epidemic's just gotten worse and worse and worse. I mean, overdoses are up about 30% over the past year, I think. And, especially around Black men. They're bearing the brunt of the burden of the drug war. They always have. And that's their communities. And, that's manifesting itself in the overdose statistics right now, too. So I think with drug policy, like there are some silver linings. There are states like Oregon that are taking a kind of a decriminalization approach. So I think we have to pay attention to what's going on with laws there it's not just about decriminalizing drugs or legalizing drugs. It's about public health taking ownership of that issue, taking it back from jails and prisons, taking it back from police, saying, we know how to do this. This is for us. And it's about the revenue. I mean, so a lot of the funding, like the defund movement, is really about, it's a refund movement to me too. It's like, it's giving the money back to institutions that are more capable of providing harm reduction services. So medication assisted therapies, methadone clinics, buprenorphine. I mean, they're basic tools that we have just a wealth of evidence that work. They're safe. They help people keep their jobs, keep their families. And it's just insanity that they're so poorly available. And so I think it's, a lot of it has to do with taking the savings that we can generate by reducing incarceration. I think that's definitely a piece of it, but I think that's not going to solve all of it. It's really like pumping money that we haven't been into creating an infrastructure for addiction services and harm reduction. I think it's just, again, not to be repetitive, but insanity that we haven't done so yet. And I think, just the toll of a criminal record, I think too, a drug arrest, like just like the very basic contact that people have with the carceral system for issues that touch on drugs, people who sell drugs, I mean, there's these economic issues that make selling drugs a very kind of understandable economic choice for a lot of people. And I think that we have, we missed the ball on focusing on that hypocrisy that exists with marijuana legalization, kind of the capitalism taking over things like marijuana. And, meanwhile, you have people rotting in prison cells who were, entrepreneurs and, like just got caught in a system that, about to use some swear words, but, just like truly just dump them in a system and have no regard. So I think there's a retroactive kind of reckoning that needs to take place with drug policy too, to free people that have been damaged, and so and having their livelihoods taken away with an intergenerational effect. So yeah, I think it's just, we have to keep fighting on all fronts for sound drug policy. And yeah, that it just takes so many forms. It's hard to articulate a career clinical thing. So I'll stop there.
Thank you too, Dr. Cloud, for that. And you mentioned something about how men had been most impacted, obviously, during the draconian policy era around drugs, et cetera. And so I want to turn to Maryland, right? And right now, the fastest growing population in prisons consists of women. And how is the incarceration of women impacting the health of communities? And then I'll turn to Dr. Mueed, and then we'll have some round of closing comments and some questions.
Thank you for that question. Incarcerated women, again, come from communities that are underserved, impoverished, facing a lot of health issues, mental health issues. And so when you incarcerate women, you really break up the families, just like when you incarcerate men. But it's a little different for incarcerated women. Most incarcerated women don't have the support, of a partner when they're inside. And so there's hundreds of thousands of grandmothers taking care of children, on a pension that they've earned or a Social Security check. And so the impact of that, removing that income from a family that's oftentimes already broken, where there's, a single mom trying to take care of multiple children who herself is experiencing various levels of trauma. Over 60% of incarcerated women have minor children, children under the age of 18. And so we know these are school-age children. So when women are incarcerated, it exacerbates the school to prison pipeline. To not have a parent at home supporting with the child's education, being available to help them learn and develop and grow as young people and individuals, it's really difficult. And so when you incarcerate a woman, especially for long periods of time, if they have children, it devastates the community and the family, because those children are then left there without a maternal influence oftentimes. But also when you incarcerate women who have not had children, oftentimes they're incarcerated for so long, they never have an opportunity to bear a child if that's something that they wanted to do. And so we've talked about some of these long sentences, drug policies, and legislative practices from the 70s and 80s and 90s that have created these really long sentences and made it really difficult for folks to parole and get out of prison. And when they return to the community, what's left oftentimes are all of these barriers and collateral consequences that stem from a conviction record. And so, breaking up a family and incarcerating a woman for any period of time without giving her or them the resources that they need to address trauma, I think continues to further damage the community. And most institutions, jails and prisons, are not trauma informed. They don't provide trauma informed care. They don't address the issues from that the woman needs based on the community in which they've come from. And additionally, the types of employment that is available, the type of labor and jobs that is available for incarcerated women, those skills are oftentimes not transferable to the community. So it's really hard for a woman to be released, especially after a long period of time, and have the skills necessary to get a job, almost any job. You're muted.
Absolutely. I keep muting myself. And absolutely, I think it's certainly relevant. And as we now have entered into the first day of what is deemed Women's History Month, although I acknowledge that it's every day, but I think it's certainly appropriate to look at how the criminal legal system or carceral system is impacting women, since there has been an uptick over the years of women in incarceration. I want to have this final question with Dr. Mueed, and then we'll transition to some Q&A and some final thoughts, obviously, from our panelists. And we thank you for joining us today. But Dr. Mueed, can you just weigh in on mental health following incarceration and the effects on the community?
Well, that certainly is a very weighted question, because we're asking, with that question, we're asking three questions, actually. One, what was the mental health of the person when they came, living in these communities which can cause domestic colonies? What was their mental health then, there, right? Then we ask the question, what experience did they have while incarcerated? So that's a second layer of the question. that's embedded in the question you ask. And then the third question is, part of the question is, okay, what happens when they come out? So you're coming out confused, disoriented, angry, all these emotions are happening all at the same time. How are you accepted back into your own biological family? How are you accepted into the community from which you come? We have many, there's a thing called Not in My Backyard, right? Where many nonprofit organizations are trying to create safe, trauma-informed services for formerly incarcerated persons. And the community is up in arms and says, no, not here. What do you mean? It's happening anyway. So you have all these barriers. So now you come out of incarceration without any support. And then when you look at it from the point of view of women facilities, oh my God, it is such a disparity in terms of how we don't have enough women-centered facilities when they come out in the first place, right? For 35 years, I worked as a social worker in New York City. And at one time when I was working for Phase Piggyback, when we opened up our residential, it was co-ed. But because of the men and women, right? It's a natural kind of thing happening, right? But it was creating so much disruption, we wound up going to an all-male facility. But I'm sure that's happening many times, and many facilities don't even consider the women in the first place. So when you talk about mental health coming out, you're going right back into a situation where now you are ill-equipped, you're overstressed, and you have less resources. New York State is a very funny place. I mean, when you think about this, we had one governor who created Rockefeller drug laws, right? We have another governor who then expands the prison industrial complex system, right? And then we have another governor who says, wait a minute, when you're looking at the numbers, these numbers are not working out. Let's start to reduce the prisons, right? So where are we now? Where we are now is saying to the correctional facilities, offices, right, and their different associations, that your lifespan is cut down to 54 years, right, compared to your counterpart that may be 79 or 78 years. We have to say to them, we have to get converts on our side of the question saying, how can all human beings be treated in a respectful manner where all our health is actually secured? Once we bring more resources on our side of the question of reform, then we'll be able to help those individuals who find themselves incarcerated. And of course, as has been already said, how do we prevent them from going to incarceration in the first place? We're talking about what social determinants of health, where you live. It was Eddie Ellis, the former public health advocate, Eddie Ellis, who said that out of 13 neighborhoods in New York City, I think they fill up like 75% of the prison industrial complex. And of course, this goes back to the 13th Amendment. When I ask people, I used to teach at Columbia University, I used to ask my students, is slavery legal in America or not? Everybody said no. The first thing they'll say is no. I said, well, go back and read Article 13. It says that involuntary slavery and involuntary servitude is prohibited. Then they say, what? Except in the punishment of a crime. So we move right into the convict lease system, and it hasn't stopped. It only has gotten bigger. And of course, Michelle Alexander says that we have more people incarcerated than we had enslaved persons in like 1860. This is crazy. We have to have a social movement that all citizens can be given the opportunity of having mental health, physical health, and only then can we ensure the mental health of formerly incarcerated persons.
And we have a couple of questions. I want to get to those questions. I know in the chat, one of the participants from the audience just raised around the substandard nutrition in food and how that contributes to poor health outcomes for people that are incarcerated or detained. So I just wanted to lift that up. But
Mr. Ward, let me add to that, if you mind. And COBRA has created what's called the harm report, right? The harm report is looking at epigenetic consequences of trauma. And in that report, it talks about the need for nutrition that could actually ameliorate those kind of problems. So it's not only the food that they eat in the prisons. What about these food deserts? in the communities in which they live. So all these things are interconnected. You can't really take out one from the other. They're all interconnected. So food becomes a very important part of it. Because with epigenetics, which says it's not only what happens in terms of your gene structure and how those genes get actually expressed, but also having the environment that's going to support your mental, physical, and spiritual well-being. You're muted again.
Absolutely.
And I put in the chat, where people can go and get the harm report from NCOBRA.
Absolutely. And there was a question that was raised too. And the question is, how or will we hold accountable the racist ways people were incarcerated in the past? Because new policies and laws only works with the courts for the present sentences, which was a question, and anyone can answer that question. So I'm just putting that out there. That was from one of the participants in this. So anyone care to answer that? Don't all speak up at once.
Okay, so not only is this Women's History Month, but it's also what is called the Decade for People of African Descent, from 2015 to 2024, with 3 principles: recognition, justice, and development. So there are international forums that's been put in place, such as the Permanent Forum for People of African Descent. Malcolm X says that it's not just a civil rights question or problem, it's a human rights one. And only when we start to make these international connections will we see the kind of progress that we're looking for. So now with this permanent forum put in place, we can feed them information, and then in turn, see, America has signed on to what is called CERD, which means they have to do a review. I think it's like every 4 years or so. But us private citizens, we can do what is called a shadow report. We have to get involved with these mechanisms that have levers that will be able to actually change public opinion. When people are educated, then they know what the issues are, then they can make certain demands. But without being informed, knowing that these mechanisms exist, these levers exist, we won't push them. So we have to move beyond the civil rights movements, which are good in the first instance, but it's not big enough, right? In CERD, it talks about special measures. It talks about special rights of people having a right to remedy. And that's why we're demanding reparations within COPE.
Got it. And there's another question that to those who have served as health practitioners within the carceral institutions, I know Dr. Rice, certainly Dr. Clark and others, as someone who hopes to do similar work, they're curious about how you internally navigate the tension between supporting individuals inside and upholding institutions that incarcerate them. So anyone care? Dr. Rice, I see you're smiling. And so anyone care to answer? Dr. Rice, Dr. Clark, or anyone for that matter? Dr.
It's
Rice?
a fine line to walk. And Rhode Island is very small, so I think it made it easier for me. But you have to support the correctional officers if you want to be successful in supporting your patients. So you can't sort of put up an adversarial, or even sometimes even pointing out the system is messed up. It's just going to interfere with your work. So I had to really compartmentalize, I'm providing the best care possible for my patient, but I have to respect everybody that's around me and try and bring in the officers to be part of not necessarily the healthcare team. It took me about 4 or 5 years, but eventually officers would come to me and say, can you check out so-and-so? She doesn't seem right today. So, having that trust helped me find problems earlier, sort of know when, somebody was acting a little different and letting the officers know it's safe to come to me and I will see the person, and recognizing the humanity in all of us. A lot of the officers come from the same community where the patients are coming from and have been equally traumatized and continue to be traumatized by the racism within the system. Who becomes a lieutenant, who becomes a captain, who becomes a warden. There are racial disparities there as well. If you don't mind, I wanted to go back to the nutrition also for a second.
Sure.
We did a study early on and found that women gained on average 2 pounds a week, which was probably a result of the stress, the lack of exercise, and a terrible, terrible diet. So somebody's in for 10 weeks, they've gained 20 pounds. So that also adds to the problem with some self-esteem, your clothes no longer fit. Now somebody's developed hypertension, more likely to have diabetes, and causes a whole host of other problems. So I think the nutrition, I went to these correctional conferences, nutrition, and people were so proud that they could feed people for $1.50 a day. And that to me seems criminal, that we feed people such poor diets. You know, they may meet the legal standard, but that is adding to the negative health impacts of incarceration.
Thank you for that. And this is for Dr.
Andre,
Rice, right? I want to just
can I ask a question?
No, we have a few minutes left, Dr. Muid. I want to try to get others in. And so, Dr. Rice, this question is for you. Do you have recommendations for academic resources or spaces where students this person who's asking the question can be engaging with those discussions outside of the classroom when they are not offered within the classroom? And I'll try to get you in, Dr. Muid, for the sake of time, because we have maybe about 10 minutes left or so.
Sure. So let me start by saying I think that the work that David Cloud is doing and Chris Wallerman are doing they offer some excellent resources for those public health students to, I use their resources in my class. There's work from the Prison Policy Initiative that offers a wealth of information. I think, we also understand that this topic is a very local topic. And so finding resources at the local level is typically very challenging. And so we have to rely on even folks like the work of journalists who are sharing broadly the stories and experience of both people behind bars, as well as sort of in the academic space, because I don't believe that sort of all knowledge comes from these peer-reviewed journal articles, right? I think we have to have a breadth of information to inform what we're learning about the system. And so I think that there are a couple of resources that are, the National Institutes of Health are doing much more of a focus on understanding mass incarceration and public health, and have been publishing lots of resources relatively recently. The American Journal of Public Health had an entire issue in 2020, 2021, dedicated to understanding this connection between mass incarceration and public health. And I would say that this world in public health is relatively small for the people who are publishing in these academic spaces. So once you figure out who's doing the publishing, I would say start to follow those folks, because that's where sort of the academic conversation is happening. But I would say never rely solely on those resources. There's also human impact partners out of San Francisco who are producing a lot of information around making the connection between public health and systems of health and well-being. And so I think that those are great starts to sort of unpacking. But I also think along with getting a better understanding, you got to do some of that historical research. So reading things by like the new Jim Crow, even things about understanding the segregation in housing. Right. So I think we have to develop a breadth of knowledge around social and political the social and political climate that's been created in this country to understand how the system sort of came to be. So I think that would be my recommendation for someone interested in sort of digging deep into the academic setting. And I had some thoughts about working behind bars, but I'm happy to sort of table that for other folks to jump in and ask questions.
Sure. I mean,
I'll type them in the chat.
Sure. Thank you so much, Dr. Rice, too. And we're going to get back to you, Dr. Mouid, but as we get ready to move toward closing, just want some thoughts from Victoria and Marilyn, that's some closing comments and thoughts, and then we'll turn to you, Dr. Mouid, and obviously Dr. Cloud and Dr. Clark. Just some closing comments as we move toward wrapping things up. Victoria?
I think what we can take away from the COVID pandemic behind bars is that it has exacerbated and highlighted all of the inequalities and flaws of prison medical care and our carceral system. So, and it's a system that's working as designed. And as Marilyn quoted Dr. Angela Davis earlier, it sweeps away people. It doesn't actually fix any of the social problems. And so I think that when we're looking at this pandemic, we can see all of the places, it highlights all of the places that need to be addressed for the 2 million people inside, because we're not going to get them all out of jails, prisons, and other carceral settings overnight. So these are systems and policies and practices that need to be changed and challenged, while also looking at ways to stop funneling people behind bars. I dropped in the chat an article I did, for which I interviewed Ms. Ralston several years ago, about medical copays in prison, so which deters many people from seeking healthcare. Dr. Mouid, Dr. Rice, Dr. Clark have all talked about the health issues that people come in with to jails and prisons. And then if you are charged what is the equivalent of a $200 to $300 copay for those of us on the outside, for people who make pennies on the inside, you're not going to seek care unless you actually need it. And California is one of the few states that does not do that anymore, thanks to the advocacy efforts of folks like Marilyn Ralston. So I want to also point out that people on the inside have constantly been fighting these battles to not only improve conditions, but also to keep fewer people from being funneled into these systems.
Thank you for that, Victoria. We'll turn to Marilyn, followed by Dr. Mouid and Dr. Clark and Dr. Rice and Dr. Cloud for like a minute comments as we move toward wrapping this up, unfortunately. 90 minutes goes really quickly, folks, as you can see. Dr. Mouid?
Yes, thank you.
Marilyn, I'm sorry, Marilyn did Dr. Mouid.
Thank you, Victoria, for those comments, and thanks for sharing the article. Just briefly, I'll say that prevention is key. You know, if we really want to dismantle mass incarceration, if we want to abolish the current prison system that we have to build healthier communities, stronger communities, and we can do that by investing in the communities, investing in healthcare, mental health care, in education, in creating urban gardens, food spaces, recreation in parks. We know what the answers are. You know, it's going back into the communities that have been robbed of resources or never been given resources, and provide those resources. And so, you know, the defund movement has been mentioned, and I think that's what it's really about. Abolitionist practices are about building communities, while we also dismantle systems of oppression and domination. And so if we can transfer those funds back to the people, because this is what we're talking about. We're talking about people and the needs of the people, and make those communities healthier, stronger, and safer. There'd be no need for prisons or jails, or even trying to unpack what's wrong with this criminal legal system at all. The carceral state would not exist. We need to put the money where the money needs to be, and that's in the hands of the people that need it the most.
Thank you. And Dr. Mouid, in 1 minute.
Yes, thank you. When you look at when I used to be the advisor at Columbia University's Graduate School of Social Workers, and many of my students, in fact, their placements were at Rikers Island, I would say to them, read the article by Peter Navarro, "What is National Health Policy?" Because what he does in this article it says that it's not just individual determinants of health, it's not only social determinants of health, but he creates the third category, which is called social empowerment determinants of health. How do you start to organize people in such a fashion where you're building a cumulative social movement? And I'll try to find that article and put it in the chat, but that's a very good article. I use it to design my clinics to say that not only when you come out of an individual session or a group session, how are you going to give them resources to other organizations that have a particular point of view of the subject matter that's going to raise up the whole community? Thank you.
Thank you. And turning it to Dr. Cloud, some closing comments in a minute.
Sure. I think just to echo what's really been iterated is that we need public health. We need the imagination of public health. The American Public Health Association did promulgate a policy statement that directly mentions abolition of carceral systems as a priority. And within that, there's like 4, I guess, 5 buckets, and they mentioned incarceration, divestment and reinvestment, developing non-carceral systems of accountability, rights restoration, and this funding for research. And I think that's like, referencing something like that is a basic tool that I think people in public health can start to reference to really fill in the meat of what needs to go under there. But I think it's back to the imagination question of really using what we know to imagine a world that we don't need the carceral system and what systems need to be in place instead of that. And the other thing I'll say is that I think there's a need for focusing kind of on intersectionality of some other issues that are going on, things like the climate crisis and prisons and jails and buildings that are uninhabitable and should not be places where human life exists. And so I think we have to continue to use public health arguments to be very creative in how we dismantle those at the same time as we create an entirely different system. Thanks.
Absolutely. And we encourage all of you who have joined and who have followed this amazing panel today. You can go to the Fortune Society, www.fortunesociety.org, to learn more about this work and the work that Fortune is doing, and also our advocacy work there. I want to turn to you, Dr. Rice, for a 30-second closing call. And I apologize, it's a disservice to you and Dr. Clark to give you 30 seconds only, right? When I know you'll have just such a breadth of information. But Dr. Rice, any closing comments?
It's okay, I'll take my 30 seconds. I think that in order for us to be able to reimagine new systems of care and well-being and support, I think public health practitioners need to dig into understanding the system and dig into really reckoning with our complicity in perpetuating the system, and then get busy doing the work.
Dr. Clark?
I think everybody's already said it. The only thing that I will add is compassion. We're all human beings. We all have the same basic needs, wants, desires. I think if people had a little more love in their hearts and recognize each other as human beings, we probably wouldn't be in this place, but we are. So let's just try and build compassion wherever we can.
Thank you for that, Dr. Clark. And I want to just really acknowledge our amazing comms and other leadership team, Sarah Hirschhorn, obviously, Kendall Shepard and Karen Hadou, just for their leadership in putting this amazing panel together. And thank all of you as leaders and experts in the field for spending time with our audience about this really, really important issue. We will be circling back to have a second round of this conversation in the latter months to come to see if there's any updates or progress. But in the meantime, we, on behalf of the Fortune Society, thank everyone for joining this panel, looking at the intersection of mass incarceration and public health. And we all wish that you have a great day. Thank you.